to our channel. Today we are going to start a complete revision of musculoskeletal system. After musculoskeletal system, I'll cover the skin and connective tissue. So let us start with musculoskeletal system. So the first thing we have is rotator cuff muscles. So this is very easy to remember just with the mnemonic. So you should remember the mnemonic SITS. SITS means supraspinatus, S for supraspinatus, I for infraspinatus, T for teres minor, and S for subscapularis. So these are the muscles which are forming the rotator cuff. And one thing to remember is supraspinatus and infraspinatus both are supplied by the suprascapular nerve, whereas the teres minor is supplied by the axillary nerve, and the subscapularis, according to the name, it is supplied by superior subscapular nerve and inferior subscapular nerve. Now let us understand what are the function. Mainly you need to understand that supraspinatus is the most commonly affected, or you can say it is most commonly injured, especially in trauma like that. Why it is mostly injured among this rotator cuff muscles is because you can see here it is exactly in between the head of the humerus and the acromion process. So whenever there is any pressure, like especially in swimmers and throwers who use their hand a lot, so in them there's a chance of compression, or you can say pinchment of the supraspinatus muscle in between the acromion and humerus, and this below the surface, the place which is below the acromion is called as subacromion space, and in this space you have more chance of rupture of supraspinatus muscle. Okay. And one more thing, we know that our shoulder joint is ball and socket joint, right? And this rotator cuff muscles, this whole cuff muscles are called as conjoint tendon. And one test we do for the supraspinatus, that is called as empty or full can test. We do empty or full can test for supraspinatus muscle. So if it is positive, then we can say there is pain in that muscle. As I said, infraspinatus is supplied by suprascapular nerve, and it is mainly used for external rotation of the arm and also for the abduction. Of course, even this supraspinatus is used for abduction. Even teres minor is used for external rotation, same like infraspinatus, but teres minor's one more function is it is also used for adduction. And remember that teres minor is supplied by axillary nerve. Okay, so like that you can remember, as teres minor is supplied by axillary nerve, it is used for adduction, you know, right, towards the body, abduction away, supraspinatus, infraspinatus away, teres minor towards, subscapular is internally rotating. How to remember the subscapular is internally rotating? Because you can see it is like internal, these are like outward, these are internal. So like that I remember subscapular for internal rotation, and also it adducts, ADD, okay, not ABD. These two only are ABD, teres minor ADD, and even subscapularis ADD. And one more thing, subscapularis is innervated by C5 to C6. Okay, and tendonitis is a pain when you abduct your shoulder joint, then that is called as tendonitis. Okay, now coming to the arm abduction, some important points. 0 to 50 degrees is done by supraspinatus, that is abduction. Okay, it is supplied by suprascapular, as I said. 15 to 90 degrees is done by deltoid. Remember that deltoid is the primary abductor and the major abductor of the arm, and it is supplied by axillary. So axillary supplies deltoid and also teres minor, right? Now trapezius and serratus anterior, these both are used especially if you want to abduct your arm which is beyond 90 degrees, greater than 90 degrees, trapezius, serratus anterior. And this trapezius is supplied by accessory nerve, serratus anterior by long thoracic. If you want, you can remember SALT as a mnemonic, serratus anterior, long thoracic. Okay, so now let us start the upper extremity now. Actually I put a mnemonic for this, like AM, RM, you are, like that. Once I am RM, then what you are. Okay, like that I remember. So AM means axillary, musculocutaneous, radial, median, ulnar, and recurrent branch of median. Now you might think why to remember this order, because if you remember this, you can also remember the nerve roots easily. For example, axillary C5 to C6. After C6 you'll get C7, right? So C5 to C7. Next after that you'll get C5 to T1. The same for median also. And next comes ulnar, which is C8 to T1. And recurrent branch of median nerve is C5 to T1. Discussion on upper extremity nerves. So first let us start with axillary nerve. You can see axillary nerve root is C5 to C6. So here let us understand by means of this diagram. So axillary nerve is commonly injured whenever there is a fracture for the surgical neck of humerus, and also whenever there is anterior dislocation of humerus. So you can remember axillary nerve is related to the injuries of humerus, okay, surgical neck fracture of humerus and also anterior dislocation of humerus. So in this case the axillary nerve may damage, and you know that axillary nerve mainly supplies the deltoid muscle. So if there is loss of deltoid muscle, innervation by axillary nerve, it will lead to loss of abduction, that is which is greater than 15 degrees abduction. If you remember here, 15 to 19 degrees abduction is done by deltoid, which is a primary abductor. So if there is no axillary nerve supplying it, then we may lose greater than 15 degrees abduction of the deltoid muscle, and also there will be loss of sensation over deltoid and also the lateral arm, because the lateral side of the arm is also supplied by the axillary nerve. Next, let us understand about musculocutaneous nerve. So musculocutaneous nerve is damaged or injured or mainly because of upper trunk compression. That is, the musculocutaneous nerve roots are C5, C6, C7. So whenever there is any upper trunk compression, then it may affect a musculocutaneous nerve. So actually musculocutaneous nerve normally supplies the biceps muscle of a hand, and also so what happens now if the musculocutaneous nerve is damaged, the biceps muscle may not get a reflex, so there is decreased biceps reflex, and there will be also loss of forearm flexion and supination. The forearm flexion means like this, right? So there will be loss of forearm flexion and also supination. Supination means this side, right? So there will be also that. And remember that the sensation is lost over radial and dorsal forearm. This is the forearm radial or dorsal side. So in the radial and dorsal side of the forearm, there will be loss of sensation, but there will be loss of flexion and supination in the forearm mainly. So you can remember like musculocutaneous is somewhat related to forearm, right? Because motor one is loss of flexion and supination of forearm, sensation one is loss of sensation over radial or dorsal forearm. So next let us discuss about the radial nerve. The radial nerve is C5 to T1. So radial nerve C5 to T1, it is mainly related to compression of axilla, because you can see it is towards the axilla. So whenever the axilla is compressed, it may get injured, or whenever there is Saturday night palsy, that is sleeping with arm over chair, and whenever there is mid shaft fracture. So if you remember, axillary nerve is when neck of the humerus fracture, radial nerve is when mid shaft of the humerus get fractured, or whenever a person is doing repetitive pronation supination, like if we use the screwdriver, we do repetitive pronation and supination, right? This is pronation, this is supination. So if you continuously do like this also, then the radial nerve may get affected, and this will lead to injuries above the elbow. You can see here this, if this is elbow, right? So if the injury is above the elbow, then it will lead to loss of sensation over the posterior of the arm. This is the anterior, right? Now in the posterior of the arm there will be loss of sensation, and also in the posterior of the forearm there will be loss of sensation, and also in the dorsal hand. So arm, forearm and hand, back, all of this dorsal surfaces, sensation is lost whenever there is an injury above the elbow in the radial nerve, okay? And this will also lead to wrist drop. The wrist may drop like this whenever there is loss of sensation for the radial nerve, okay? So next, coming to injuries below the elbow. So if the injuries are below the elbow, then what happens is it will cause distal paresthesia without wrist drop. That is important. If the injury is below elbow, there is no wrist drop. That is important. Only paresthesia, okay? And remember that the tricep function and posterior arm sensation are spared in midshaft fracture. So whenever there is a midshaft fracture, the tricep function will be normal, and also the posterior arm sensation will be normal. But remember, if the injury is above the elbow, you may lose the sensation on posterior dorsal of the arm, dorsal of the forearm, and also dorsal of the hand, and also there will be wrist drop. But if it is below the elbow lesion, then only paresthesia but no wrist drop. This is important regarding radial nerve. Now let us start a discussion on median nerve. So median nerve, the root is C5 to T1, okay, and it is mainly affected in supracondylar fracture of humerus. So supracondylar fracture of humerus will be somewhere over here. So here if there is a fracture, that is leading to the proximal lesion of the nerve. Actually the median nerve, you can see here, this is the median nerve. Okay, let us follow it. You can see it is going till your hand. So it has a proximal lesion and a distal lesion. The proximal lesion will be in the supracondylar fracture of humerus, and the distal lesion will be here because of the carpal tunnel syndrome. In carpal tunnel syndrome, whenever there is a wrist laceration, in that case you will get the distal lesion of the median nerve. Okay, and the presentation of this median nerve distal lesion will distal or proximal lesion, it will mainly lead to the ape hand or hand of benediction. So I'll show that picture now. So here you can check out, this is the ape hand, or also called as hand of benediction. So in this diagram also you can see this is the area which is supplied by the median nerve, and this is supplied by the ulnar nerve. So ape hand or hand of benediction is caused because this two fingers, ulnar fingers, they can flex, but the the median nerve supplying fingers can't flex, including thumb and the two lumbricals. So this can't flex in the case of hand of benediction or ape hand. So there is also loss of wrist flexion and function of lateral two lumbricals, and also opponent's pollicis, which is present in the thumb, and also abductor pollicis brevis, which is used to abduct the thumb, and also flexor pollicis brevis, which is used to flex the thumb. So all these muscles are lost, and there is also loss of sensation over the thenar eminence. This is a thenar eminence, and also there's loss of sensation in the dorsal and palmar aspect of lateral 3.5 digits. So 1, 2, 3. This 3.5. You can see this blue color till half. So this lateral 3.5 digits sensation is also lost because of the proximal lesion in the median nerve. So proximal lesion means, as we discussed before, in the supracondylar area, proximal lesion of the median nerve, and the distal lesion of the median nerve is in the wrist region. That is because of carpal tunnel syndrome. So in the median nerve we need to remember two lesions. One is the proximal lesion, one is the distal lesion. Whenever there is a proximal lesion problem, that is in the supracondylar region of the humerus, then there will be loss of sensation of this lateral 3 lumbricals, 3.5 digits lumbricals. So next let us move on to the ulnar nerve. So here you can see this is the ulnar nerve. Okay, ulnar nerve is also having again like the median nerve proximal lesion and the distal lesion, because ulnar nerve you can see it is also going till the hand. Okay, so ulnar nerve proximal lesion is fracture of medial epicondyle of humerus. You can see this is the median side, this is the lateral side. Okay, so whenever there is a medial epicondyle of humerus, here the point where there may be fracture, and that will lead to the proximal lesion. And whenever there is a fractured hook of hamate, that is a distal lesion here in the wrist. Okay, from the fall on outstretched hand, or compression of nerve against hamate as wrist rests in handlebar during cycling, in that cases you may get this kind of lesion in ulnar nerve. So ulnar nerve will lead to ulnar claw on digit extension. So now I think you can guess it, because this is the ulnar side and this side will be mainly affected here. So I will show you the ulnar claw now. So here you can see in this diagram the claw hand or the ulnar claw, where you can see the little finger and this side is affected because that is mainly supplied by our ulnar nerve. And in the case of ulnar nerve lesion, there will be the radial deviation. So always remember, if the ulnar nerve is affected, there will be radial deviation. If radial nerve is affected, there will be ulnar deviation. So opposite always. So here the ulnar nerve is affected, so you will have radial deviation. That is nothing but your hand will be moving towards your thumb finger side whenever you want to flex your wrist. Okay. And this radial deviation which I am discussing now is mainly because of proximal lesion. So proximal lesion means, if you remember here, proximal lesion of the ulnar nerve I discussed in the medial epicondyle of humerus. Okay, and there will also be decrease of flexion of ulnar fingers. Flexion of ulnar fingers, flexion means closing of this two little and this finger, because of the loss of abduction and adduction of the fingers, that is intraossei, because intraossei are also supplied by ulnar nerve, and even the thumb adduction and actions of ulnar two lumbrical muscles are lost. Okay, and there will be loss of sensation over ulnar 1.5. Here let me show here. There will be loss of sensation of ulnar 1.5 digits, including the hypothenar eminence, because of ulnar nerve lesion. Now lastly we are going to discuss about the recurrent branch of median nerve. Okay, the recurrent branch of median nerve, it is affected due to superficial laceration of the palm, and it will also lead to ape hand. Okay, we have discussed already ape hand, okay, or also called hand of benediction, already seen. That may also be caused because of this recurrent median branch. Okay, and there is loss of thenar muscle group, opposition, abduction and flexion of thumb are lost, and there is no loss of sensation. So one thing to remember, in the median nerve even the sensation is lost, but in the recurrent branch of median nerve the sensation is not lost, only the motor action is lost. So that is all about the upper extremity nerves. One more key point you need to notice that is always whenever you see the loss of sensation, that loss of sensation will be mainly due to the proximal lesions of the nerves. But here you can see in the recurrent branch of median nerve, there is only a branch which is near the wrist. There is no proximal lesion, so there will be no sensation loss here. Okay. Now let us continue with brachial plexus lesions. So in this brachial plexus mainly you need to remember that it consists roots, trunks, divisions, cords and branches. Okay, so you can also use this mnemonic like remember to drink cold beer. Okay, and one thing you need to see in which lesions what kind of problem is there. So first, Erb's palsy. Erb's palsy is also called Vater's tips. It is mainly affecting the upper trunk. You can see upper trunk is affected by Erb's palsy. And next, Klumpke's palsy, which is causing a claw hand. It is affecting the lower trunk. Next, coming to wrist drop. Wrist drop is affected in the cord. Third, you can see here this is a posterior cord. So posterior cord is affected in wrist drop. And winged scapula, we know long thoracic nerve is affected. And deltoid paralysis, or deltoid, you know, it's an abductor and it is supplied by axillary. So axillary nerve, you can see here axillary. And Saturday night palsy, which is leading to wrist drop. So radial nerve, wrist drop. Okay, and difficulty flexing elbow, variable sensory loss. It is because of musculocutaneous. And decreased thumb function, hand of benediction, ape hand. It is because of median nerve, right? So 8 median. And intrinsic claw of hand, that is causing a claw hand, that is because of ulnar, because ulnar supplies the intrinsic muscles of the hand. So like this we can remember this 9 points. And now let us move on to this Erb's palsy. As I discussed before, Erb's palsy is because of upper trunk problem. This is also called Vater's tip. So how to remember this is mainly you should first check out the muscles. After checking out the muscles, you can easily say what nerves are affected and their actions also. So first, deltoid muscle is affected, infraspinatus is affected, biceps brachii, you can remember like dip. Okay, so Erb's tip palsy, tip dip, you can remember like that. So if deltoid is affected, automatically you will say axillary nerve is affected, infraspinatus is affected, suprascapular nerve is affected, biceps brachii means you know it's musculocutaneous affected. So like this you can guess the nerves and their actions. So if deltoid is affected, abduction will be affected here, infraspinatus is affected, lateral rotation is affected, biceps brachii is affected, flexion and supination are affected in this case of Erb's palsy. So what is going to happen here is the arm will hang by the side. You can see the arm is going to the side, and there is also lateral arm is medially rotated. And the arm is extended and pronated. So this is a problem which is seen in Erb's palsy. So the nerves are axillary, musculocutaneous, suprascapular. So what are the causes? In infants, because of lateral traction on neck during delivery, especially in delivery problem, birth, trauma is case in the case of infants. In adults, it is trauma to the neck traction, that is falling on head and shoulder in motorcycle accidents. So in motorcycle accidents, you can see Erb's palsy, which is mainly upper trunk problem, which is affecting dip muscles. So according to that, you can guess the nerves. Now let us see Klumpke's. I remember Klumpke like a pumpkin. So if someone is falling, especially adult who is forming from a pumpkin tree, like that I remember trauma from a pumpkin tree. In infants, in the case of upward force on arm during delivery. Okay, upward force on arm. If you put more force on arm during delivery, that may lead to Klumpke's paralysis. So what muscles are affected? Intrinsic hand muscles, lumbricals, introitial, thenar, hypothenar. So how to guess the nerves? Actually, the lumbricals are supplied by median nerve and introitial are supplied by ulnar nerve. Thenar, you know, thenar side, thumb side, It is supplied by median nerve, hypothenar supplied by ulnar nerve. So clearly you can see median and ulnar nerves are involved here. Okay, and we have also seen the causes. So what is the problem here? If there is no lumbricals, actually lumbricals normally flex the metacarpophalangeal joint. So for example, this is a hand, here this is metacarpals, these are the phalanges. So this flexion here, flexion means like this. Okay, this flexion here is caused because of this lumbricals, and they extend the DIP and PIP. So lumbricals actually form this shape like this, so L shape. So if there are no lumbricals, what happens is the fingers will become flexed like this, and they form a claw shape, that is a claw hand. So there are no lumbricals, introsia and thenar, hypothenar, all these are lost here in Klumpke's palsy. Now let us move on to thoracic outlet syndrome. What is the problem here? Actually here there is a compression of lower trunk and subclavian vessels, most commonly within scalene triangle. Actually here lies the scalene triangle, and here there is compression of lower trunk and also subclavian vessels. Okay, so this is leading to the problem here. And another cause is cervical rib. You can see some extra rib coming from the C7 vertebra. Actually from here the rib should not come, but there's an extra rib, that is cervical or anomalous first rib, which is also seen in Pancoast tumor. So because of this also there is outlet syndrome, because here the subclavian vessels and lower trunk is compressed between the cervical rib and the first rib. So there is atrophy of intrinsic hand muscles. It will also lead to ischemia, pain, edema, and due to especially vascular, that to venous compression. So cervical rib occur mainly after hyperextension or flexion. This is called whiplash. Now finally coming to wing scapula, you know that the lesion of long thoracic nerve, especially the nerve root C5 to C7, is causing this problem. You can see here this wing scapula. You can check this by outstretching hand against the wall, then you can clearly see this. And here the affected muscle is serratus anterior, that is inability to anchor the scapula to thoracic cage and cannot abduct arm above horizontal position. So that is the problem here in winged scapula. Let us continue with wrist region. Okay, you know this is the wrist. So first we need to remember this bones name. These are the proximal and distal bones. So there's a mnemonic like she looks too pretty, try to catch her. Okay, you can remember like that. And the most important bone which is fractured always in the wrist is a scaphoid bone, and the scaphoid bone you can feel it in a snuff box. You can see this is a snuff box. So here you can feel the scaphoid bone mainly. It is palpable anatomical snuff box, and it is this is the most common injury. The wrist is most commonly affected in fouche injury. Fouche means fallen outstretched hand. Okay, especially the complication of the scaphoid fractures include avascular necrosis and also non-union due to the retrograde blood supply from a branch of radial artery. Actually this radius, here you can see radius, so you can remember radial artery supplies the scaphoid proximal part and distal part, but the proximal part is mainly dependent on the retrograde blood supply. So this may lead to non-union and avascular necrosis. Occult fracture not always seen on X-ray. You can't see occult fractures on X-ray. And next is dislocation of lunate. Is mainly going to impinge. It will impinge the median now. So that will cause a carpal tunnel syndrome. You know, this is a carpal tunnel. And here this one, this blue area is a carpal tunnel. Above you can see anteriorly you have the flexor retinaculum, and inferiorly you have the carpal bones. Actually if you see here this plane section here, this place is where you find the carpal tunnel. Above the carpal tunnel you can see this is a Guyon's canal through which the ulnar artery and ulnar nerve passes. So whenever there is a lunate bone is affected, then it affects the median nerve, and that will lead to carpal tunnel syndrome. And you can see whenever there is a fracture of hook of hamate, so this is a hamate here, if its hook get affected, then it may impinge on the ulnar nerve, and that will lead to Guyon's canal syndrome. You can see this is a Guyon's canal, there is a carpal tunnel syndrome. So carpal tunnel syndrome is because of lunate bone. Guyon's canal syndrome is because of hamate bone. And one more thing you remember, hamate, hook of hamate, when it affected, it will also affect the distal part of median nerve. One more thing about wrist is you can see here the wrist flexors, that is you can see this wrist, this is flexion. Okay, flexion of wrist is mainly done by the median median and ulnar nerve. So mainly it is because of the flexor carpi radialis and flexor carpi ulnaris. Okay, and the wrist extension means, this is flexion of wrist, this is extension. So wrist extension is mainly done by radial nerve. It is because of extensor carpi radialis longus and extensor carpi radialis brevis and also extensor carpi ulnaris. So these are the muscles which you need to remember regarding the wrist flexors and extensors. Now let us discuss about hand muscles. You can see this is the thenar eminence, this is the hypothenar eminence. Thenar eminence is supplied by the median nerve. Hypothenar eminence supplied by the ulnar nerve. Okay, so what are the muscles which are present in this thenar side? As mainly opponent's pollicis, which is used for opposition of the thumb. You can see like this thumb finger is able to oppose the other fingers because of opponent's pollicis. And there's also abductor pollicis brevis, which is used for abduction of the thumb, and also there's flexor pollicis brevis, which is for the flexion of the thumb, and superficial head, which is deep head by ulnar, which is supplied mainly by ulnar nerve here on this side. And now coming to hypothenar, which is it's ulnar nerve supplying it. There's opponent's digiti minimi because it is a little finger, digiti minimi. Abductor digiti minimi for abducting this little finger, and flexor digiti minimi for flexion of this this little finger. So both groups perform the same function like opposition, abduction and flexion. You can see either on thumb or little finger side, you need to oppose the finger, you need to abduct the finger, and also need to flex that finger. Now one more thing, easy way to remember about the interosseous muscles is dab and pad. Dab means dorsal muscles, backside of your hand. This dorsal muscles are used for the abduction. Abduction means like this, okay. And the palmar muscles are used for the adduction. You can see this is adduction, okay. So pad, dab, you can remember. Dab means dorsals, abduct. Pad means palmars, adduct. So these muscles are mainly supplied. These are both interosseous muscles, and they are mainly supplied by our ulnar nerve. And you need to remember that lumbricals are the muscles which are present in the first second, which are supplied by the median. First second, you should always start counting from the thumb side, and the last one will be little finger. So this thumb and this index finger, this both are supplied by median, whereas the third and fourth are supplied by ulnar. So actually these muscles flex at MCP joint, means MCP is here, they flex here, and they extend at PIP and DIP. So always remember lumbricals means L shape like this. So you can see here they're flexing at this and they're extending. So this is a L shape which is formed by the lumbricals. And finally here you need to remember how the ulnar claw, hand of benediction, median claw, okay, gesture form. So where we want to try to make a fist is mainly in hand of benediction, and in okay gesture we actually want to make a fist like this. But in the case of hand of benediction, you can see we are closing only this two fingers, but we are unable to close this fingers because this side, this thumb thenar side, if you remember, it is supplied mainly by the median nerve. So here the problem is in the median nerve, but it's a proximal median nerve problem. In the proximal median nerve problem, you are not able to make a fist of this median side fingers. In the case of making a fist in okay gesture, there's a problem in proximal ulnar nerve. So that's why if you want to make a fist, but these two fingers are not closing, you can see here, because there's a problem in the ulnar nerve. And here in ulnar claw and median claw, here you are trying to extend the fingers, but you are unable to extend these two fingers, means you can clearly say you are not able to extend these fingers. That is the problem is in the ulnar nerve, right, distal ulnar nerve. And here in the median claw, you can see you are trying to extend the fingers, but you are unable to extend these three fingers. So here the problem is in the median nerve, that is in the distal medial nerve. So by this we complete about the hand and upper extremity nerves. Next we'll go to